Harper is a 4-month-old Caucasian boy who has recently arrived at the Royal Children's Hospital with his mother Sadie and father George for his recommended 4-month-old developmental checkup. Harper is Sadie and George's first child and was born 2 weeks before his due date. Sadie had to be induced and underwent a C-section after she experienced a stalled labour which lasted more than 7 hours. Apart from this fact, Harper was overall born healthy, with no apparent complications at birth. While undertaking a full physical assessment on Harper, the paediatric nurse notices a murmur whilst auscultating his chest. For the rest of the assessment on Harper, the nurse finds no other abnormalities and otherwise he appears well and is content in the current environment. His vital signs are all within normal ranges apart from his oxygen saturation, which is currently sitting at 84% on room air, and his heart rate, which is slightly tachycardic at 175 beats per minute. Sadie and George state that they have no severe concerns about Harper's health but report a bluish tinge to his lips when he cries heavily. His lips usually return back to normal colour when he stops crying, however they report that this has been happening every couple of days and they believe it is happening more frequently. Harper is slightly smaller than the average boy, weighing 6.5 kilos and measuring in at 61 centimetres in length. However, he is tracking well against his height and weight growth chart. He has just received his 4-month-old immunisations and is up to date with all his other immunisations. After hearing the heart murmur, the nurse alerted the paediatrician in charge, Dr. Urban. After consultating with each other, Dr. Urban ordered the chest x-ray and echocardiogram to ascertain whether any cardiac abnormalities were present. The test showed that Harper's heart is demonstrating signs and symptoms very similar to that of Tetralogy of Fallot, and Dr. Urban has confirmed that this is the correct diagnosis. When asking further questions about how Harper is at home, Sadie says that he is a good feeder, however it can sometimes take a long time for him to feed, with him stopping and starting throughout, with Sadie describing this as though he is trying to catch his breath between each few sucks. Sadie is currently on maternity leave from her job as an interior designer and plans to return to work in roughly a year's time. George runs his own construction business and is currently working full-time. They are in their own home in Camberwell and have a pet golden retriever called Arlo. Sadie's parents live in Kew and are able to help out with Harper when necessary. Tetralogy of Fallot is one of the most frequently encountered cardiac abnormalities in infants, with it accounting for up to 1/10 of all congenital heart conditions at birth. It is characterized by the presence of 4 anatomic cardiac features, all of which collectively lead to inadequately oxygenated blood to circulate throughout the body. To correlate the clinical symptoms we see in Harper, the Tetralogy of Fallot, we first have to understand the pathophysiology and role each cardiac feature plays in TOF and how these exhibit themselves clinically. The first unusual cardiac feature found in Tetralogy of Fallot is defined as pulmonary stenosis. Pulmonary stenosis is demonstrated by the narrowing of the right ventricle outflow tract in the heart. Typically, deoxygenated blood flows throughout this tract and into the pulmonary artery, which ultimately makes its way into the lungs in order to be oxygenated, from where it can then be pumped throughout the rest of the body. Naturally, if this outflow tract is narrower than what is commonly expected, less deoxygenated blood would make it to the lungs, right? Due to this lack of blood flow into the lungs, the body's compensation mechanisms attempt to counteract this. This is where the second cardiac anomaly of Tetralogy of Fallot manifests. In response to the lack of blood thrown through the right ventricular tract, the heart's muscular tissue, known as the myocardium, hypertrophies, becoming thicker. This enables the heart to contract harder and force more blood to be propelled past the stenosis and into the lungs. With us now understanding that the heart has to contract harder and faster in order to shun an adequate supply of blood into the lungs, we can see that Sadie's description of Harper catching his breath between sucks, accompanied by his tachycardic heart rate, can be correlated to his pulmonary stenosis and right ventricular hypertrophy. The third irregular cardiac feature present in patients with Tetralogy of Fallot is termed ventricular septal defect, or VSD for short. VSD occurs when there is a growth-related abnormality or interruption of the intraventricular septum formation during the heart's formation in the womb. This interruption of the septum being formed manifests itself into what can be simply put as a hole in the wall that separates both the left and right ventricles. In a patient who only has ventricular septal defect, blood is shunted from the left ventricle into the right due to the pressure in the left ventricle being higher than that on the right. To simplify this means that oxygenated blood is pushed into the deoxygenated blood's pathway. Therefore, a mixture of both bloods is pushed into the right ventricle, which, as discussed before, ultimately makes its way into the lungs. In Tetralogy of Fallot, however, due to the narrowing of the right ventricular tract, normal blood flow into the right ventricle is impaired, and therefore the pressure in the right ventricle becomes higher than in the left. Naturally, blood flows from an area of high to low resistance, and in Harper's case, and the majority of those with TOF, the deoxygenated blood then makes its way into the left ventricle, mixes with oxygenated blood, and is then pumped throughout the rest of the body. Again, if we relate this back to Harper's case, and if we now understand that the blood circulating around his body is not fully oxygenated blood, we can see his clinical symptoms of low oxygenation saturation levels and cyanosis when feeding occur as Harper's body is not adequately oxygenated. The fourth and final cardiac anomaly seen in Tetralogy of Fallot is when the aorta overrides a septal defect and is known as an overriding aorta. In a standard heart, the aorta is placed above the left ventricle. This is so that when the heart contracts, oxygenated blood is pumped straight into the aorta so that it can be pumped throughout the rest of the body. This provides the body with the oxygen-rich blood and nutrients needed in order to maintain normal bodily functions. An overriding aorta is defined as when the aorta is not in its usual position and it instead sits on top of both the left and right ventricles. When the heart contracts, the overriding aorta allows both oxygenated and deoxygenated blood to be shunted into the aorta and then throughout the body. The arterial blood running throughout the body is therefore deoxygenated to an extent, and subsequently, the lungs and heart have to work harder in order to be able to sufficiently provide the body with the blood and nutrients it needs in order to maintain normal function. When relating this back to Harper's case, we can correlate his tachycardia to his heart working strenuously in order to provide adequate blood perfusion to the rest of his body, his low oxygenation saturation due to his arterial blood being only partially oxygenated, and his cyanosis when feeding due to him only being able to have sufficient oxygen when he is able to fully breathe.
Corrective surgery of TOF is aimed at providing favourable long-term outcomes, and although it has been noted as a definite cure, it is important to recognise and be aware of potential issues that can arise in patients like Harper, who are most likely going to have surgical intervention. Optimal heart function is significantly important in providing organs with oxygen-rich blood, and although surgical intervention is predominantly successful in achieving this, recent studies have shown that later in life, patients with a congenital heart defect are more susceptible to developing issues such as chronic pulmonary valve insufficiency and infective endocarditis. Pulmonary valve insufficiency, also known as pulmonary regurgitation, PR for short, refers to a leaky valve and is commonly seen in patients who have required a repair of TOF. The pulmonary valve plays a distinguished role in the heart, helping control the flow of blood passing from the heart to the lungs. In a normal functioning heart, the pulmonary valve divides the right ventricular outflow tract from the pulmonary artery. The valve closes in diastole in order to prevent regurgitation of deoxygenated blood returning into the right ventricle. However, in those experiencing PR, this does not occur. Symptoms of pulmonary regurgitation are benign in many patients for a number of years before becoming a core problem. If Harper was to develop this condition in his later years, clinical manifestations may include a spectrum of complaints, from palpitations, syncope, dyspnea, to a general decline in exercise tolerance. Upon assessment, nurses may expect to see elevated jugular venous pressure, peripheral edema, jugular venous distension, a low-pitched brief diastolic murmur upon auscultation, and an elongated QRS complex within electrocardiographic findings. This condition is severe, and if not appropriately cared for, the patient is predisposed to a range of extremely detrimental issues, such as ventricular systolic dysfunction due to a decline in the body's compensatory mechanisms, severe arrhythmias as a result of the progressive enlargement and stretching of the right atrium and ventricle, which altogether can ultimately cause sudden cardiac death. Harper may not experience any of these symptoms for a number of years after surgical intervention. However, the severe ramifications highlight the importance of education in nurse-patient interaction in order to create awareness of further management that may be needed. Infective endocarditis, also known as IE, refers to an infection which is caused by bacteria that enters the bloodstream and goes on to settle in the endocardium, valve, or vessel of the heart. The relationship between congenital heart defects and pediatric IE is significantly rising, with 11 per 100,000 people developing the condition. Those like Harper, who may undergo a complete TOF repair, are put at a higher risk of developing IE as they may have multiple cardiac lesions, such as intracardiac defects and valve regurgitation, which create potential targets for infection. Infective endocarditis comprises of predominantly 3 critical elements, including proposing structural abnormalities of the cardiac valve for bacterial adherence, the adhesion of circulating bacteria to the valvular surface, and the ability for adherent bacteria to surface and propagate as vegetation. To break it down, in TOF, the turbulence of blood flow damages the endocardial lining. This exposes the underlying collagen and tissue factor, which then causes platelets and fibrin to adhere. A non-bacterial thrombotic endocarditis, also known as an NBTE, is formed, which is essentially just a blood clot. The thrombosis is non-bacterial as the pathogen has not actually entered the bloodstream yet. Studies show that dental procedures in children is one of the most common causes of this becoming bacterial. Once the bacteria enters the bloodstream, the immune response is initiated, and usually the pathogen is killed. However, occasionally the bacteria float around long enough to find an NBTE and join, as this serves as a perfect location to attach and set up an infection, also known as a vegetation. Like all conditions, symptoms can vary from person to person and within different time frames. However, most common reported symptoms of IE include fever, chest pain, weakness, blood in the urine, chills, sweating, white spots in the patient's mouth, pain, and swelling. Upon assessment, nurses may expect to hear a murmur of the heart, an irregular heartbeat, and may see a low red blood cell count as well. Infective endocarditis is a life-threatening condition which can do irreversible damage to the heart if not caught and treated correctly.
Goal setting is an essential aspect of an individual's care. It allows families like Harper's and the interprofessional team to work together and set family-orientated goals in regard to potential issues that may occur. SMART goals are often an acronym used in order to develop specific, measurable, achievable, and realistic goals in a timely manner. Harper's family may set a goal to achieve the earliest recognition and intervention possible in regard to the potential development of pulmonary regurgitation. Due to the severe ramifications that could potentially arise if Harper experiences pulmonary regurgitation, it is important to recognize the condition as soon as possible to avoid irreversible harm. Following a successful repair, Harper's family may agree on setting a 6-monthly checkup with his cardiologist in order to observe any of the symptoms stated earlier. As a young boy, it is reasonable to agree that Harper may be exposed to high bacterial risk environments or procedures such as dental surgeries throughout his life, with studies showing the strong correlation between the relationship of IE and CHF due to dental procedures. A goal Harper's family may agree on is to always use preventative measures such as prophylactic antibiotics during these times in order to avert IE from occurring and improving quality of life.
The goal I'm going to discuss for this case study is to ensure that family members cope effectively post-surgery. There are many nursing interventions that I will discuss to ensure that Sadie and George feel reassured and have a wide variety of strategies to utilise during the recovery process. It is vital to identify the importance of parental support post-complete intracardiac repair surgery for Tetralogy of Fallot in infants. It would be an incredibly overwhelming and daunting process for first-time parents, Sadie and George, to endure for their first child, Harper. All families will cope differently depending on individual and familial factors, but it is important as the nurse to provide as much education and reassurance as possible during the post-surgery period. In circumstances like Sadie and George's, parents tend to experience higher incidents of stress, anxiety, depression, and hopelessness. Unfortunately, for families who lack an understanding of the diagnosis and surgery, are likely to experience higher psychological distress as a result. It is important for the nursing staff to understand the trauma associated with their newborn getting a diagnosis of Tetralogy of Fallot. The term The team will need to provide Sadie and George with all the information they need to adequately care for Harper post-cardiac surgery and positively impact his recovery. Nurses providing family-centred care. Family-centred care is a care model that includes parents and strengthens the collaboration between families and the healthcare providers. This is essential to ensure that parents' well-being is maintained during this traumatic time. The nurse could invite Sadie and George into the recovery room if this is allowed. The nurse should firstly provide the parents with education as to what to expect post-Harper's surgery. It can be extremely overwhelming seeing your newborn infant with several drain tubes, a catheter, respiratory aids, intravenous lines, cardiac monitors, and other post-op equipment attached. Therefore, nurses need to explain what each device is for and explain in detail how it works, how it benefits their child, and when it may be removed. This can significantly reduce anxiety if Harper's parents feel as though they have an understanding. The nurse may want to pre-brief parents on their expectations of their role for the post-op period. For example, when their child is stable, holding Harper's hand can help the child from distractions and provide reassurance for the parents. Being involved in the care, changing nappies, and feeding the baby would help Sadie and George to reduce stress and anxiety associated with Harper's condition. This can also be a good time for nurses to spend time further educating the parents on post-op care and familiarising them with signs and symptoms of injury or infection post-surgery, so parents can identify any signs of hypoxia, heart failure, or infection. Providing psychological support and utilising family members. The interconnection between parental coping plays a significant role in the child's recovery and well-being long-term. Ensuring that the nurse has created a trusting and therapeutic relationship with Harper's parents will allow for an open discussion and space for any questions they have regarding the post-op process. Ideally, the nurse is able to learn the coping styles of Harper's parents and feel comfortable enough to encourage them to adopt positive attitudes during this stressful time. The nurse should plan follow-up sessions and establish the best way for parents to contact health professionals if they have any questions upon discharge. Nurses can suggest the benefits of seeking psychosocial support during this time. This may include psychologists, social workers, maternal health specialists, spiritual care, and particularly participation in any information sessions regarding TOF, or being able to ask cardiologists any questions they may have post-surgery. As the nurse, you have the ability to create these therapeutic relationships and allow the family to confide in you, which can be extremely useful tools for parents in these situations. Sadie and George may be interested in connecting with families who have been through similar situations via online support forums and gaining advice on how others managed at home after discharge. Fortunately, Sadie's grandparents live close by in Kew and are willing to help their daughter and son-in-law whenever they may need it. It is beneficial for family members to share carers' load to allow a better quality of life for Sadie and George during this stressful period. The parents' well-being will impact Harper's recovery. That is why it is imperative that nurses provide the family with early psychological intervention programs. If these nursing interventions are established early on, it will enable Sadie and George to achieve their goal and utilise all the resources that need to cope effectively post-Harper's complete intracardiac repair surgery.
I will be discussing the goals and nursing interventions relevant to patients with TOF in the pre-surgery care. One priority goal is to ensure that the patient is kept comfortable, which can be achieved with a number of nursing interventions, while also taking into account the family of the patient, providing adequate support and education on the condition. As Harper is their first child, both parents may be experiencing high levels of anxiety due to Harper's new diagnosis. Therefore, forming goals that are established with the parents to include their desired outcomes and enable them to feel involved in Harper's healthcare. Nursing interventions are essential to provide appropriate care specific to the child's needs and to make the patient feel comfortable. With TOF, there are a number of nursing interventions that can help to manage Harper's symptoms whilst in hospital and prior to surgery. As Harry discussed the pathophysiology of TOF, A specific position called knee-chest position can be beneficial for a patient with this condition, as when they bring their knees to their chest, it aids to rise systemic vascular resistance, which in turn decreases the right to left shunt that occurs, and in result allows an increase of blood flow into the lungs, with the aim to improve symptoms that Harper is experiencing. Another nursing intervention that is necessary to ensure comfort for Harper is regularly charted analgesia. A clinical manifestation of TOF can include pain and discomfort during heart contractions, which can cause distress for Harper. Regular analgesia, if needed, should be given to limit pain and distress for Harper. Breathlessness is a symptom of TOF, which Harper experiences at feeding time. A nasal gastric tube could be inserted to reduce possible distress at feeding times and ensure he is getting adequate amounts of milk. Not only can milk be fed through the nasal gastric tube, but also some medications to create less disturbances to Harper and improve overall comfort during his stay in hospital. Sadie and George are extremely important to consider, as they will most likely be experiencing high levels of stress due to their child being quite unwell and having a new diagnosis to understand, as well as treatments and long-term outcomes. Our goal pre-surgery would be to ensure that both Sadie and George have sufficient time to sit down with the doctor directly looking after Harper, as well as the cardiac surgeon. This will allow both parents to be able to openly discuss the condition, the pathophysiology, as well as what will occur during the surgery. From a nursing aspect, the nurse looking after Harper could sit down with Sadie and George and answer any further questions they still might have regarding TOF. The nurse looking after Harper could print off some information sheets from appropriate sources so the parents are also able to read up on the condition later, as they may not be able to take in large amounts of information straight away, due to this being quite an anxious time for them both. The nurse assigned to Harper could also prepare Sadie and George on what to expect the day of the surgery and run through the general overview of the day so both parents know what to expect, with the intent to reduce the amount of stress on the day. It will assumedly be quite challenging for both Sadie and George, and discuss that they will be allowed to stay with him for as long as possible.